So I was going to talk about a different kind of flow diversion. We've heard a little bit about intravascular flow diversion. So what I was going to talk about is what is commonly referred to as intrasaccular flow diversion. And I'm going to specifically focus on one device because I think the amount of data that we have for this one device is of a much higher level than we have for any other competing technologies in this space. And I think it also kind of reflects the direction that this field is progressing in. So typically what would happen is we do a really small study, say for Neuroform, we did a 30-patient HDE study was done in the European Union, and that led to an HDE approval in the United States. And really, we still haven't done too much of a formal investigation of that device, and it's been commercially available now probably for almost 2 decades. So this is a completely different type of a story, and again, I think it reflects sort of the evolution of the space. So I have a number of disclosures that are listed up here. What is the web or the woven endobridge? So it looks like this. There are 2 shapes of it that are now in common use, but basically it's a self-expanding braided nitinol mesh that's shaped either like a ball or like it's called an obelisk spheroid, which basically is a ball where you cut the 2 ends off the ball. And so the outer braids are held together at the base by these markers that are made out of platinum iridium. And so you have these very fine nitinol strands that are micro-braided into these platinum iridium markers that hold them together. And that's attached to a flexible pusher, so it's pushed through a catheter just like any other coil or stent. And it's delivered through one of 3 catheters. So there's a via 33 for the big devices, so the 10 and 11 go through the via 33. Then there's the 27 and 21 devices that span down to smaller sizes all the way down to 3 millimeters. And then there's a 17 device that's coming. So soon we'll be able to deploy these ball type devices through catheters that are the same size that we're using now to coil aneurysms routinely. And I think this is going to be a pretty big advance in terms of what we're doing here. They're attached via an electrothermal severance of a polymer. So it's similar to the way that the microvention coils detach or the micros coils detach. So the concept is you have a wide neck bifurcation aneurysm. This one's not particularly wide necked. I'll show some other examples. And I'm pretty much, in terms of follow-up, forced to show outside of the US examples because we can't show follow-up for any of the US cases that have been in the trial. So the idea is that we'd have a definitive treatment for this, just like we consider pipeline to be a definitive treatment for many sidewall aneurysms, whereby in one step you'd be able to, with a high rate of technical success and high rate of safety, catheterize the aneurysm and cure it quickly. And so you drive the device, the microcatheter in the aneurysm, you deploy the web device in place, and then you detach it, and then the aneurysm is occluded. And so rather than having to put coil after coil after coil in, sometimes with Y stents and balloons, conceivably you could just go up, deliver a catheter, place this ball inside the aneurysm and detach it, and you can imagine how quick this case goes. And one of the things that at least has occurred to me through my time of doing cases is that the longer I'm up in somebody's head with catheters, the less likely that the patient's going to do well. And so I think the faster that you are able to do a case, yet still do it carefully, the more efficient the case is, the safer it is. And I really think that that's the way everything is going in this space. And so if we look at the web device at the interface between the parent vessel aneurysm complex, these microbraids actually have a very, very low porosity and a very low pore density. And so the porosity centrally is 100% where all the microbraids converge on the marker. But as we go out distally, that decreases. But the smallest level metal surface area coverage that you get anywhere in the web is about 60%. And that's versus a pipeline that has about 35% metal surface area coverage at the neck. And so a web is like 2 perfectly placed pipelines where there's no overlap of the strands. And so you can imagine the level of flow diversion that this gives you at the neck of the aneurysm. And then also you can imagine that this provides really an excellent lattice for neoendothelial overgrowth. And so when we look at like the rabbit elastase aneurysms, these very quickly endothelialize in after you have thrombosis, and then tissue grows over these quite avidly, especially centrally where that marker is and that little recess is. And so just during the course of the trial, things have evolved quite a bit. So the device transitioned to the single layer device from a double layer device that we started out with. We started out with this. It was 1 layer inside of another layer. These were pretty stiff to deliver, but then the single layer devices were much easier to deliver, much more conformable. And then they became enhanced visualization devices, so they added stuff to the nitinol to make it a little bit more radio opaque so we could see it better. And so these were the 2 devices that we did the vast majority of the trial cases in. The current versions of the web can treat aneurysms between 3 and 10 millimeters. There are multiple SKUs of the SL device and just single SKUs of the SLS device for aneurysm treatment. And really the key thing in putting it in, the key technical point, is you have to have really good apposition between the web device and the aneurysm neck, because any leak here will lead to incomplete treatment and filling of the aneurysm. And so sizing is really the absolute most important thing. And you want to oversize the devices a little bit. There's actually a formula that we use to measure the aneurysm and size it appropriately. The device is made out of a microbraid, so even when oversized and deployed in the aneurysms, these braids are so thin, the strands that make up the braids are so small, that the actual radial force on the outside of an aneurysm, once fully deployed, is much less than you'd get from, say, equivalently sized coils. So considerably lower outward force on the aneurysm that you can measure versus placing standard coils into the aneurysm. And you can imagine, too, we're delivering basically a stent that's closed on both ends, so a braided nitinol device through a microcatheter. So you need considerable support to do these cases because you want very precise control of the microcatheter within the aneurysm. And so we use like a Neuron Max type guiding catheter, Navion, either 058 or 072. We get pretty high up into the head, and then the via microcatheter through that. And so the difference, again, between the web and a lot of these other studies is there's actually quite a bit of scientific data about the web and how it works in terms of having core lab independently adjudicated studies where the patients were monitored. So the web's only been in clinical use for 6 years. There have been 3 GCP studies with primary endpoints that have been completed and 2 GCP studies that are still ongoing. So combined, we have over 350 patient years of follow-up with core lab adjudication, independent monitoring, and AE adjudication of data. And so that's a lot different. I remember when this case was done in 2010. Again, this was done by Cleach in Erfurt, and I got to know him because I actually proctored a bunch of his first pipelines. And so he's a guy that's really interested in trying out new technology. And so he had this fairly wide neck, complicated bifurcation MCA aneurysm. And you can see here in the 3Ds, you get a little bit better view of it. And so this was the very first in man case where he delivered a double layer web into the aneurysm and was able to get really good occlusion of that, which was durable at follow-up. So that's an 8-week follow-up. And I'm sure he's got longer follow-up in this patient now. So we went from doing that one case to actually doing quite a few additional studies. So the webcast study was done in the European Union, and then the French Observatory was done after that. And so these 2 studies are completed, and I can show you complete data with primary endpoints in these 2 studies. Webcast 2 is enrollment's completed, and the patients are through follow-up, but the data are not currently available. The US WebIT trial has completed enrollment last year in March, or earlier this year in March. The follow-up data at 1 year will be available this coming March. And then Clarice, which is a study of ruptured aneurysms, is currently ongoing in France. And so these are all the trials that have been completed or are currently ongoing with the web. And so the French Observatory and webcast data are fully available now. And so these, we're looking at adequate occlusion as a primary endpoint. So this is complete occlusion or some neck remnant. And this is 114 patients in these studies of wide neck bifurcation aneurysms that were treated with various versions of the web. And so the feasibility was excellent in this. So they're reporting a 97% technical success rate. So in patients where a web was opened, they could deploy it in the aneurysm almost 100% of the time. There were really only a couple of failures. And some of them were related to just not having the correct device available commercially at the site at the time of the case. So the aneurysms included in these studies were truly wide neck bifurcation aneurysms. So the mean size was 8, but the mean neck diameter was about 6. And so these aneurysms were both ruptured and unruptured. So unlike the stents where we're putting something in the parent artery, we can use these in both ruptured and unruptured aneurysms, just like we use with coils. So this is something that sort of differentiates us from the intravascular flow diverters. And in fact, some of the patients in here were ruptured, but as in all these studies, except for Clarice, most of the patients were unruptured. And the most common location of aneurysms that were treated with this device, interestingly, is the MCA bifurcation. So what this represents as well is not only a move towards sort of a simpler, more straightforward, technically solution to treating aneurysms, but this is going to allow us to take many aneurysms that would have otherwise been clipped, and they'll now be much more accessible to endovascular techniques with devices like this. Again, as you see here, the amount of antiplatelet therapy varied quite dramatically in these 2 studies. So almost half of the patients were on dual antiplatelet or single antiplatelet medication, but you can see there were also some that had no antiplatelet medication. So for ruptured aneurysms, typically we're doing these with no antiplatelet medication and just an aspirin afterwards. For unruptured, we'll do dual antiplatelet medication at the time of the treatment, but then discontinue that after the treatment, just treat the patients with aspirin once the web is in place, provided there's no parent artery impingement by the device. So this is, I think, really the most important part of this. And so if you look at the French Observatory and webcast data combined together, major morbidity, meaning somebody has a stroke at 30 days where the Rankin score goes greater than 2, is extraordinarily low, 2.7%. And the morbidity after the first month is 0%. So when you continue to follow these patients, there's not really delayed morbidity that these patients are occurring. And so you can imagine trying to do stent-assisted coiling in a similar population of bifurcation aneurysms. You just wouldn't expect to have these types of results. If you look at mortality, procedure-related mortality at 12 months was 0%, so they treated 100 patients and nobody died of a procedure-related mortality in that time. And all mortality at 12 months was 4%, but 3 of the 4 were non-neurological, so these were related to cancer or some other type of problem. There was only one neurological death that occurred, and it was related to a giant aneurysm that continued to expand after treatment with a web. So adequate occlusion at 12 months is 82%. And again, when you first look at this number, it seems a little bit low. But if you look at core lab adjudicated data for coiling, it's actually quite good. And I'll show you some of that later. Once you start having a core lab look at results, it's remarkable how different the rates of complete occlusion are than they are when they're reported in a self-reported series. Retreatment at 12 months was only 4%. And so if you look at the web and the webcast and French Observatory studies, and then some of these other sort of multi-center and single-center retrospective studies have been reported, the rates of adequate occlusion are typically around 80 or 85%. So there are 2 additional studies that are online that are going to become available soon. So US WebIT trial was completed over the past couple of months. And so we started enrollment in this trial in 2014 in August. The first case was done in Memphis by Adam. And you can see the enrollment was actually quite quick. And then the last enrollment was in March of this year. So we were able to enroll 150 patients over the course of just about over a year in the trial. So these, again, were wide-necked aneurysms, so 6 millimeters height and width, and average neck size was about 5. And most of these were unruptured, as they were in the previous study. Most common location in our study was basilar apex. So we were very careful about picking aneurysms for this. They had to be reviewed by Adam and myself, and agreed that they could be included in the study. And the basilar apexes are particularly technically nice because access into the aneurysm is very straightforward. And that's something that's important for this. MCA and ACOMs, though, did represent a significant proportion of aneurysms in the study. And surprisingly, ICA terminus technically is one of the most difficult areas anatomically to treat with the device, which I can talk about later if that's of interest. So the web was implanted in 148 of 150 cases where the devices were open, and adjunctive devices were very uncommonly used. So balloons were allowed in the study to aid positioning of the device, but stents were not allowed. This counts as a treatment failure. So there were 2 stents that were used during the course of treatment for parent artery impingement. So the average time of the procedure, so web time is the amount of time from the insertion of the web to removal of the delivery system, was only about 20 minutes. And the average fluoro times were 30 minutes. And so if you're thinking about treating wide neck bifurcation aneurysms, it can take you 30 minutes of fluoro time to get a Y construct in place. So here, without coiling and just putting the device in, these devices can be really fast. So at my place, when we're doing trial cases, Henry and I try to scrub in together. So like I'll get all this stuff prepared while he's going up and catheterizing the aneurysm and stuff. So if you have 2 people working, this is a 10 by 8 partially calcified MCA bifurcation aneurysm. It's got all these lobulations and quite wide-necked. So if I was going to do this endovascularly, we'd probably put Y stents into something like this. And so this is what the working angle looks like. And you can see there's a down-the-barrel view of both of the M2s coming out of the M1. So we were able to take our Navian guiding catheter up through a neuron max, catheterize the aneurysm with a via 33, and then open the device in the aneurysm. So that's the device open in the aneurysm. We can then do a quick run and see how it looks. And so with 11 minutes of total fluoro time, we can treat this aneurysm. And again, I can't show you the follow-up of it, but you can see how nicely the web device is opposed to the aneurysm. That circle where the parent vessels are superimposed on each other is maintained. And you can see the level of stasis that you have within the actual aneurysm, which was it's a good case for us, but Henry's quite disappointed because he feels that this is going to represent the end of a lot of MCA clipping that he enjoys doing. So most of the devices that were deployed in this study were the SL device. Almost probably 3/4 of the devices that we put in were SL devices, and that's the one with the flat edge. And you could see in that previous case that flat edge looks like a surgical clip that's been placed along the outside of the vessel. which allows you to treat these really wide neck bifurcations. So major morbidity in the Webb trial was only one case out of 150 cases. So 0.67% of patients had any kind of meaningful stroke or event during the time of the Webb trial. So again, if you tried to treat 150 consecutive patients with stent-assisted or Y-stent-assisted coiling, you could imagine that you get into considerably higher levels of chaos than this. And there were no instances of mortality out of 150 patients that were treated at 30 days. The one primary safety event, so the one patient who had a modified Rankin that was greater than 2 at follow-up, was a patient who actually had a delayed ipsilateral parenchymal hemorrhage 22 days after the procedure. It was an ACOM aneurysm that was treated, and the patient had primary parenchymal hemorrhage in the right parietal lobe after treatment. So the guide catheter was in the right internal carotid artery, and the feeling is that this was some type of reperfusion hemorrhage from a small area of silence, sort of ischemia there. So this left her with hemiplegia, modified Rankin of 4 at 30-day follow-up. Between 31 days and 365 days, though, there have been no additional neurological morbidities or primary events of any type. There were some other minor events. I don't want to give you the idea that there was absolutely nothing going on in the trial at all. There were 7 minor ischemic strokes, meaning patients had neurological changes that were verified with diffusion imaging or not verified with imaging at all, but had stroke-like symptoms that persisted for more than 24 hours. 5 of those resolved without sequelae at 30 days, so their modified Rankin was 0 at 30 days. 2 had a modified Rankin at 1 at 30 days, but so they didn't reach a modified Rankin 2. They didn't count as major morbidity in the study. There were 5 TIAs, meaning any neurological event that was in the distribution that would make sense for where the guide catheter was or where the procedure was performed, but that lasted less than 24 hours. And there were 2 minor subarachnoid hemorrhages. One was angiographically evident, so at the time of deployment of the Webb in the first post-Webb run, there was a small amount of extravasation that stopped. That patient was actually asymptomatic when they emerged from anesthesia and didn't even have headache. That was reported. And then the second patient was a little bit confused, and on a routine post-procedural CT had some small amount of extravasated contrast on the side of the Webb deployment, but then that resolved and the patient had no sequelae from that. If we combine all of these studies that we have, so WebIT, WebCast, and WebCast 2 in the French Observatory, that's 317 patients in prospectively monitored and adjudicated studies. The overall rate of major morbidity is only 2%, and there are no mortalities at 30 days related in any of these patients related to any of these procedures. So really, again, a remarkable level of safety. And so if we compare with other therapies, it's a little bit difficult because most of the other therapies that we have are HDE therapies, and there really aren't organized studies that look at their performance. But if we look at some of the coiling studies, so we have Clarity, we have the Cerecyte coil trial, HELPS, and then the MAPS trial, and these are core lab adjudicated studies of coiled aneurysms. You can see that the rates of complete occlusion, neck remnant, and aneurysm remnant are actually quite favorable for the Webb, particularly considering these are wide neck bifurcation aneurysms, and these are all-comer aneurysms in these other studies that have been published. Really, the closest group of patients to the Webb patients that's ever been published in a prospective core lab adjudicated study are the groups of MAPS patients that had stents, because we're going to assume that those were wide-necked aneurysms. They include wide neck bifurcation aneurysms and sidewall aneurysms, which is a little bit different. So if we compare the 114 WebCast and French Observatory patients to the MAPS stent-assisted subtype, what we see is that the morbidity in the MAPS stent-assisted subtype group is quite a bit higher, so that's a major morbidity. The adequate occlusion rates for the MAPS stent-assisted coiling are considerably lower than they are for the WebCast and French Observatory data. And then the recurrence rate's also higher for the stent-assisted coiling group than the WebCast and French Observatory rates for the Webb aneurysm. So really, if we look at the data that we have, again, it just shows how the field is moving forward and how our devices are getting better and easier to use and really a lot safer. The level of procedural safety, I think, is the most outstanding thing about this device. So the level of major morbidity at 30 days is very, very low for these patients. After 30 days, really, in all these studies, and again, we have 317 patients in prospectively monitored studies. There have been no morbidity so far that's been documented between 1 and 12 months, and no procedure-related mortalities yet in any of these studies, which again I think is remarkable. The US WebIT data are again completely in line with these. So favorable occlusion rates, not 100%. The implant definitely needs to get better, and we need to learn more about it. But the adequate occlusion rate is actually pretty good, 82%. The occlusion stability is quite good as well. So from the post-procedural pictures to 12 months, 98% either stable or improving. The retreatment rates are low, and I think really this device is just going to continue to get better and better. So we're going to be able to see it better, deliver it through smaller catheters, and the delivery system and the implant itself are going to evolve and become better. And so I think really Webb is, many of the devices that we have are going to do, they're going to expand the number of aneurysms that are amenable to endovascular treatment. And so Webb is going to, I think, take a lot of MCA aneurysms and some of the more complex ACOM aneurysms into the realm of predominantly endovascular treatment from surgical treatment. So again, as these techniques continue to evolve, they've just become easier, safer, and faster. And so when you see a basilar tip aneurysm like this one, and you can just go up and put a Webb device in there and detach it, and then bring the patient back 6 months later and have a perfect follow-up with complete occlusion, I just think that this is going to win the day for a lot of these bifurcation aneurysms.